Good morning, everyone. Happy Hump Day. Thank you for joining PHCA for today's webinar, The Data of Wound Care in the Nursing Home. I'm Wendy Johnson, Executive Assistant for the Pennsylvania Healthcare Association. PHCA offers monthly webinars to members to receive updates from department staff on regulations, learn from industry experts on current trends and practices, and gain a better understanding of practical application tools to equip you so that you can continue to provide the highest level of quality care possible. Before we begin, I have a few housekeeping items to cover. This webinar is being recorded and will be made available on PHCA's website by no later than the close of business today. The webinar has been approved for 1 continuing education credit for nursing home administrators and nurses. For any nurses on the line who are in need of credits, please email me and I will email you a separate nursing credit certificate. Certificates will be emailed by close of business today, along with a link to a survey. Please complete this survey, and if you are participating in a group setting, have each participant also complete the survey. All attendees will be in listen-only mode. However, throughout the presentation, you can feel free to submit questions by using the question pane on the right hand of your screen, and our presenter will address them at the end of the presentation. Now for today's webinar. This webinar is presented by Zweli Tunyiswa, Director of Marketing with Wound Healing Solutions. Wound care presents unique regulatory risks in the nursing home market. Nursing home administrators have reacted by implementing QAPI systems to mitigate these risks. These QAPI generally focus on the micro trends that in single nursing home or in homes in their corporate unit. However, there exists a growing body of both national and state-level data that can strengthen QAPI and risk management. Nursing home administrators need to understand the trends in the data to build robust QAPI and risk management related to wound care. This presentation will provide national and Pennsylvania data related to wound care that will aid nursing home administrators and nurses in understanding the nature and scope of regulatory risks of wound care in the nursing home market. Your learning objectives for today's webinar include defining the regulatory risks related to wound care in the nursing home market, defining the wound care data sets related to wound care in the nursing home market, discussing the wound care data on a national and Pennsylvania nursing home market, exploring the emerging trends in the wound care data in Pennsylvania nursing home market, identifying the key risks in the wound care data in the Pennsylvania nursing home market, and lastly, suggesting risk mitigation strategies for wound care in the Pennsylvania nursing marketplace. Zweli, I turn the floor over to you.
Well, thank you, Wendy. Thank you for that fantastic introduction. I'd like to thank you for setting this up and giving me the opportunity to present today, and also thank PHCA for the same. So I'd also like to thank the attendees who are taking the time out of their very busy days to attend this session, and I hope to make it worth your time. Now, a little bit about me. My name is Zweli Tunyiswa. Most people, for obvious reasons, call me Z. And I just had a title change at my firm from Director of Marketing to Executive Director of Strategy. Our firm provides wound care services in the professional wound care services in the nursing home. And in this role, since 2011, I've spent a great deal of time going through the national data, the local data for the markets that we serve. My background is that of a marketer. Received my undergraduate degree from the University of Pennsylvania in Marketing and Communication Studies. Studied at the University of Pennsylvania's Annenberg School of Communication. So data and using data to understand markets is something that is really important to our firm, but also important to me personally, as it allows me to understand the market. And today, hopefully, I will share some insights that will be helpful to nursing home administrators, clinical and otherwise. The challenge for today's presentation was paring down all the data that we have, because there's certainly a lot of data out there and analysis. So my intent is to keep it fairly simple, fairly brisk, and to just sort of draw straight lines between the data and the risk mitigation strategies at the end. And like Wendy said, I'm happy to take questions at the end. If you have any, just please send it to her, and we'll just grab them at the end. So let me get started. All right, so Wendy has laid out the objectives for today's presentation, so I'm just going to skip past this. And I'm going to dive right into defining the regulatory risks about which I'm speaking. So with regard to regulatory risks, what I'm really talking about are wound tags. That is the 314 tag, which is the pressure ulcer tag, and 686, which is the tag which is replacing the 314 tag as of the end of this month. So F314 has been around for about 15 years and defined the expectations of wound care in the nursing home. And it was a data set that was defined by the federal government through its proxy, CMS. And the new tag 686, which is going to effect at the end of this month, I believe the 29th, clarifies and builds upon 314 and really sets a new level of expectation with regard to wound care, and in my estimation, a higher level of risk for nursing homes. And I'll go into why that is. So again, I know I'm repeating this a third time for past 15 seconds, but 314 is going to be replaced by F686 as of the 28th of this month. So this is an important milestone with regard to wound care in the nursing home space. So just going to go over 314 versus F686 and just putting the language side to side. And 314, as many of you know, is where the requirement of this tag is that a resident who enters the facility without pressure ulcers does not develop pressure ulcers unless the individual's clinical condition demonstrates that they were unavoidable. And 2, a resident having pressure sores receives necessary treatment and services to promote healing, prevent infection, and prevent new sores from developing. That's pretty straightforward. If you look over at 686, it's pretty much the same language, except that it emphasizes 2 things, and I've highlighted probably the most important difference between the 2 in red. And that is a resident receives care consistent with professional standards of practice. And this is a sort of an important distinction that I believe CMS is drawing. And I'll go into that a little bit more. And if you look at the second line, at the first line, it also emphasizes prevention. And we'll go into a side-by-side of essentially what a deficiency would be in 314 versus 686. So 314 basically reads that a presence of harm, negative outcomes, or potential for negative outcomes because of a lack of appropriate treatment of care will lead to a tag. And those are defined across 3 axes: potential for development of or occurrence or recurrence of avoidable pressure ulcers, right? So that's kind of the prevention angle. Complications such as sepsis or pain related to the presence of unavoidable pressure ulcers, and pressure ulcers that fail to improve as anticipated or develop complications such as sepsis or pain because of lack of appropriate treatment and care. So in summary, those 3 points really go into prevention, appropriate assessment, and treatment. Now, if we look at 686, again, we see the language that has been inserted. The phrase consistent with professional standards of practice, who may be at risk of development of pressure ulcers. So again, it's sort of focusing on prevention. And then again, providing treatment consistent with professional standards of practice to an existing pressure ulcer. And 3, ensure that a resident does not develop an avoidable pressure ulcer. And again, that language is much more explicit. The other thing is, and this is directly from the language of the new F686 tag, is that to cite F686, it is not necessary to prove that a pressure ulcer developed. And this is an important distinction. In the previous 314 tag, the language was implicit. Technically, you could get tagged even if the resident did not develop a pressure ulcer, but it was implicit in the language. In 686, they've made it explicit, that basically the patient does not have to develop a pressure ulcer, and you can still receive a tag. And this is something that I think is subtle, but very important for the wound care space in the long-term, in the nursing home. And I think people are going to see the effect of this in the first quarter of next year, where I predict an increased incidence of tags, maybe plus 25 to 30%, because in my experience looking at the data and also within our firm, we see a lot of occasions where prevention is not optimal. And I think that to make the point, the surveyors are going to set the bar high to start with regard to prevention. So one of the things that in the language that I pointed out in red was that they've articulated this term professional standard practice. And I just wanted to sort of draw it out a little further. So I pulled the ANA standard, for professional standard practice, and the ANA obviously is the American Nursing Association, and it draws those standards across all categories: exemplary professional practice standards, structural empowerment practice standards, transformational leadership, and new knowledge and innovations, etc. And basically, the exemplary professional standards are the assessment, diagnosis, outcomes, implementation, and evaluation of the wound actual care. Structural empowerment is education and professional evaluation, collegiality, and ethics. And transformational leadership is collaboration leadership with regard to the space of care that you provide. And then the new knowledge is the quality of practice, research, and resource utilization. Now, further, with regard to wound care, we can extrude professional standards to also include certification and clear-cut standards of care within wound care management. And at the bottom, you'll see that I've included the different boards that provide wound care certification. So, for example, the American Board of Wound Management, which provides a certified wound specialist certification, the WOCN-CB, which is a wound ostomy and continence nursing board, which provides certification for CWCN, CWOCN, the National Alliance of Wound Care and Ostomy, which their certification is the WCC, and I believe they have two other certifications relating to diabetic and foot care. The American Board of Wound Healing, which provides a hyperbarics wound care certification. And at the end, you'll see on the right bottom there, the National Pressure Advisory Board, which is a non-governmental organization that defines taxonomy of wounds, wound care jargon, etc., and really defines sort of the structural outlay of pressure ulcer treatment and assessment. So these, with regard to F686, are things that are going to be amplified and are going to be honed in on by the surveyors, I believe, consistent with the language that has been propagated. So I'm going to delve a little into some of the data sets that we're using to buttress today's presentation. This is not an exhaustive list. It's just a list of the prominent ones that I've used today and the ones that I generally go to a great deal. There's the Nursing Home Compare database, which is available online. There's a web portal where you can go in, type in a nursing home, and you can pull data down across many different axes or quality measures, or, for example, building size or building type. It's also available in what's called CSV format, which can be put into a database and then worked on from a data analyst perspective. In addition to that, CMS releases the nursing home inspection reports, which again generally are obtained through a web portal, but are also available in raw data file format, which can be loaded into a database for analysis. In addition to that, the MDS data set, a summary thereof is released. It's called a frequency report, In this case, I'm really talking about the M300 series in the MDS, which is related skin integrity and wound care. So that's also available via CMS's website. Unfortunately, that one is not available in a format that can be databased easily, so we have to pull that and manually create a data set that can then be analyzed. There's the Nursing Home Data Compendium, the 2015 edition, which provides a data book across multiple dimensions in nursing homes, and also strides the data further by state, which is very useful. And then with regard to Pennsylvania provides spatial data access for nursing homes. That's to say geography data, and provides what's called a shape file, which then can be loaded into a database for analysis. So we'll get started by looking at the national picture. Again, I've tried to keep this data pretty straightforward. We can go through the proverbial rabbit hole if we really start looking at each dimension. But I just want to keep it pretty simple so we can just see very simple trends in the data. So this chart represents the tags as enumerated by year from 2014 to 2016, with the rightmost tag sort of aggregating all that data. As we can see, in 2014, there were just over 1,000 tags nationally. In 2015, about 2,500, and in 2016, 2,600. And basically, the 2014 number is a little deceptive because at that point, not all states were reporting into the database at the same time. So I suspect that number is less than the actual tags that occurred. But if we just do the basic math over 2015 and 2016, we see that on average there are about 218 tags a month across the United States. And if we look at the tags by scope, that's the A through, I believe, L level, we see that most of the tags are D level tags. That is no harm tags. That's about 65%. And then we have the G level tags, which is the first level of harm, which is about 20%. And you just do the math, it's about a 75 to 25% split between harm and no harm tags. And then if we take that data and break it down by year in percentage terms, we can see that again, the D level remains the highest tag. And at a national level, there's not much movement year over year between the tags. So we see D remaining in and around 64, 65%, G in and around 20%, and then other miscellaneous tags staying pretty constant. And now when we look at the map of all the tags from 2014 to 2016, we see that there is a hotbed of tags in the Midwest, which sort of stands out to me immediately. If you look at Wisconsin, Illinois, Michigan, Indiana, Ohio, that's sort of the hotbed of tags in the country. I did the math on this. Is about 30% of the tags nationally during that time period were in the Midwest. Pennsylvania actually is pretty much in line with the number of nursing homes population. You'd expect that about 250 to 300 tags relative to its size. The ones that catch my attention for how low they are is Texas and Florida. And we know Florida has a high geriatric population. Again, looking through some of the data, I suspect there's some level of underreporting in Florida rather than the patients being better with regard to wounds. And of course, we have California that, given its population, will see high numbers for. So the next slide shows the tags by state in percentage terms. And again, the Midwest stands out. The state that stands out the most to me is Illinois, which has 10% of the nation's tags, which is, if you really think about it, so strange that it's very interesting when you dig into the information, because it seems to me that there's been an emphasis in that state on wound tags, and the surveys run almost zero tolerance policy in that state. And you see Wisconsin, Michigan, Indiana, and Ohio, like I said before, representing big percentages with regard to the wound tags from 2014 to 2016. Pennsylvania, again, relative to its size, should be in and around 4.5%, where it is. And then this is what's called a tree map. I just want to represent that same data over here in a way that you could see it fairly easily. As you can see, Illinois coming in at 9%, California at 7%, Wisconsin, another state that its wound tags are through the roof. Pennsylvania comes in about 7th position with regard to wound tags from period 2014 to 2016. Over here, we're showing the tags by state and year, just year over year. Again, Pennsylvania is pretty consistent year over year. I have a little arrow here. I'm just wondering if I can point to it using my thing. No, it won't let me. But you can see Pennsylvania year over year stays pretty consistent. If you look at Illinois, you see those high levels of wound tags, and it's actually increasing. You see also Wisconsin, as I said before, staying relatively high relative to its nursing home cohort, and Michigan as well. And again, this is percentage of wound tags, so it's that map represented in chart format. Again, we see these massive outliers in Illinois, Wisconsin. Again, Pennsylvania, not out of range for where we would expect their data to sit. Another thing that I did was to represent the data, wound tags by month, year over year. And basically, we see that there's seasonality in the wound tags. Seasonality means just generally there's an up and down trend year over year in the wound tags. So, for example, we see that in November, wound tags nationally drop pretty, about what's that, 70 tags relative to the previous month. And again, it's a Thanksgiving holiday, less time for observations, I suspect. But you see that year over year in the data. And then the high month in the data is August, which caught me off guard when I first came across these numbers. I don't really have an explanation for why that is, but it stands out in the data that August nationally is is the high month for wound tags. All right, so we're going to drill down into the Pennsylvania data, and I'm going to represent the same data as I did nationally, just for Pennsylvania. So again, we see 2014, again, probably a data reporting error over there, but we see that tags generally are in about 10 tags a month in 2015 and 2016, 272 during this observation period from 2014 to 2016. We see the distribution of the tags, again, consistent with what's going on a national basis. About 68% of them are D-level tags, and it's about 24% for G-level tags, that is harm. So it's that quarter to three-quarter split that we saw before on the national level. So Pennsylvania is pretty consistent with that. Now, what's interesting about Pennsylvania when you sort of extrude the data by year is that if you remember the slide nationally, the breakdown by scope or letter stayed pretty constant. What you see in the data for Pennsylvania is that, as we saw in the previous slide, tags have stayed relatively the same in 2015 and 16, but the tags have been, I like to call this downshifted. So they've shifted down from G down to D. And if you look at the data, you see that the D tags in 2014 represented about 50% of the wound tags, but by 2016 had moved all the way up to 75%. And you see G moving in the opposite direction, so 35% in 2014, dropping all the way down to 20% as of 2016. So it looks like the trend from the surveyors is to keep the same number of tags, but to downshift them into lower severity. Again, cannot speak to causality. It could be that the nursing homes are getting better, but it also could be that the surveyors are also becoming less onerous. Now we are going to represent the data by county. And there's some very interesting things going on here when we look at the data from 2014 through 2016. So we see the major centers, Philadelphia and surrounding counties, Pittsburgh and Northeast Pennsylvania, where we have a higher level of nursing, a higher number of nursing homes having the majority of the wound care tags. But what's interesting is, in percentage terms, how certain counties are overrepresented and some are underrepresented. So, for example, Philadelphia County has had about 4.4% of the wound tags in the state, which is almost the same as Cambria County, which is just next to just two counties over from Pittsburgh. To me, I found that very interesting, considering the sheer number of homes in Philadelphia County. Same can be said for Lancaster County, which had 4.4% of the tags, which is the exact same percentage as Philadelphia County. In the Northeast, we see a hotbed of tag activity in and around Wilkes-Barre-Scranton, in Luzerne County, Lackawanna County. So 5.1% Luzerne County, 4.4% in Lackawanna County, and even Monroe County, which is 3.7%, which, if you really think about it, relative to Philadelphia, is really high. The counties surrounding Philadelphia, especially Montgomery, Chester, you see levels that you would expect relative to all observations in the state. But this, for me at least, these observations in these Cambria, Monroe counties, Lancaster, are very interesting with regard to their level. Again, it could be that wound care in those counties is a bit more challenging, or it could be that the surveyors are more onerous in those counties, or it could be both. Again, I put up a tree map here so you get a bit idea in terms of percentage, in terms of ranking, where the counties sit. So Allegheny County has the highest level of wound tags over this observation period, followed by Westmoreland, Luzerne, Montgomery, Chester, Lackawanna, Lancaster, and Philadelphia, and of course Cambria, which to me is at least the most interesting in terms of how high it is relative to everybody else. I then show the time series data like I did with the national data. And again, we see common trends. We see the low month consistent with national being November. As well, in this case, which is more interesting, April as well. And as you can see in the data, the 2 years converged at 6 tags for that month, which we did not see in the national data. And then August, as we can see, consistent with the national trend, is the highest month for wound tags in the state of Pennsylvania. So after taking a look at some of that data, I'm going to talk a little bit about some key risks that we saw from our sentiment analysis of survey text data. Now, if you remember, when I was articulating the different data sources, there was the full text of the data that one could download and put in a database. And what we did was to put that in a database and use a piece of software for what's called sentiment analysis. Sentiment analysis is where computer algorithms can search into text and pull out patterns of words or phrases that represent discernible data And basically, it comes from social media network analysis, algorithms they use like by Facebook, Google, etc., to really drill into unstructured data and pull out meaning. And we had about 272 tags whose data we could pull from, and run this sort of sentiment analysis to see what was in the data. And of course, we read through them as well, but we used the computer just to pull out any sort of bias or risk that we run just reading them. And these were some of the key risks identified in that sentiment analysis. And again, these make sense in the wound care space. The key risks were not following skin integrity wound care protocols, wounds not being identified, prevention modalities not being in place for high-risk patients, appropriate treatment not being provided, not following wound care recommendations and or orders, simple gaps in care, where someone would develop a wound and care would not be provided in a timely manner. Error in documentation, this is a very common one as well, and miscategorized pressure ulcers. So this falls across two axes. One, they could be categorized, let's say, as not being pressure ulcer when they were, or the stage of the pressure ulcer was not accurate. So I'm going to delve into a little bit of these key risks using actual text from the wound care surveys. So an example of not following skin integrity wound care protocols, this is text directly from the surveyor's report. And basically, a review of the facility's policy entitled Pressure Ulcer Prevention, dated January 2014, revealed that nursing staff was to carry out wound treatment as ordered by the attending physician and document wound measurements on a weekly basis. And then if you read towards the end, although nursing contacted the physician regarding the new pressure sore, there was no documentation to indicate that an order was obtained to treat the wound. In addition, there was no documentation that a weekly wound assessment was done. So basically, the surveyors, and many of you know this already, come in, and one of the first things that they like to do is to say, can we get a copy of your skin integrity wound care protocol? And then they use that as a frame for the rest of the investigation and survey process. And you see this repeatedly in the data. It's the first thing they do. And they sort of, hang people by their own paperwork, so to speak. The second key risk here that you can see some of the text for is wounds are not being identified. So these are from 3 different tags. So we have the first one, review of the nursing progress notes. There was no other mention of reddened or open skin area on the back until May 15, 2014. So simply they missed the ulceration on the back. The second one, there was no documentation in the progress notes of any skin issues from the nursing staff who signed the TAR that the skin audit was complete. Again, the first entry in regard to pressure ulcer being present on resident's back was on May 8, 2014, when physician noted pressure sore mid-back. And then finally, the facility was unable to provide evidence that the pressure sore was identified and assessed in a timely manner, and that appropriate interventions were implemented to prevent the area from worsening. So again, this is a key risk that facilities have, where pressure ulcers that are manifested either at the hospital when they're coming in, they're not seen on the initial skin check, or nosocomial pressure ulcers that are simply missed. This, of course, is a big issue and something that these surveys come down really hard on and are actively looking for. Another risk is prevention modalities not in place, and this will become even more important with F686. And as we can see in the text here, it was determined that the facility failed to institute preventative measures to prevent the development of pressure sores and to treat pressure sores that developed for 2 of 6 residents. Now, this specific tag, the pressure ulcers developed, and they got the tag, but like I said earlier, under F686, this by itself would be a tag, which again is a subtle but important thing that 686 brings into play. The next risk is the appropriate treatment not provided. Based on clinical review, record review, observation staff interview, and resident interview, it was determined that the facility failed to ensure that a physician-ordered treatment was provided to 1 of 9 residents sampled with pressure sores. And then in the second observation, interview with registered nurse confirmed that the physician was not notified about resident R5s and pressure sore, and there was no treatment ordered. And then the next risk that we have here is the appropriate treatment not provided. And in the first observation, we have facility failed to acknowledge a wound consultant's recommendation and implement treatment timely for 1 of 3 residents sampled with pressure sores. And again, you have mentioned the facility's policy wound management. And in the second observation, it was determined that the facility failed to provide pressure relief as ordered by the physician for 1 of 30 residents who was at risk for developing pressure sores. The next slide we have is gaps in care. The language here is facility failed to timely act upon and identify skin impairment and provide prompt and necessary treatment and services to prevent worsening and promote healing of pressure sores for 3 residents. And this timeliness aspect as well, it goes back to what we talked about in 314, 686. It was implicit in 314. It is now going to be explicit under 686. And again, I suspect that these types of gaps in care tags are going to increase. It's explicitly stated in the new language. Error in documentation. I mean, anyone who's dealt with wound care knows that documentation is extremely important, not only for medical legal risk, but also from regulatory risk vis-a-vis 314 or 686, because that's what the surveys use to basically analyze what has been done and whether or not appropriate treatment is in place or prevention modalities are in place. So in this case, interview with the director of nursing revealed the facility did not complete skin sheets because she did not believe blisters were pressure ulcers. So you have a documentation error, and then you have a miscategorization error at the same time. And then the facility did not track measurement of residents' blisters. Clinical record review for resident 46 revealed nursing documentation that resident developed a blister on right hip. Review of evidence report revealed staff would monitor the area and apply skin barrier cream daily. There was no evidence that that was assessed, and the area was tracked weekly. And finally, we get to miscategorized pressure ulcers. As I said, not saying something is a pressure ulcer or not determining the appropriate stage of the pressure ulcer. So here you see the skin assessment of this area was conducted by employee 1, was not accurate as this nurse identified the pressure sore as a bruise. And this one is tough because sometimes people, the clinicians, specifically at the nursing home, sometimes they're not able to tell the difference, and certain because of the physical presentation. So a lot of times the way it's written in the tags, it's kind of arguing that there was obfuscation, where in many terms it might have been an education element or just ignorance in terms of being able to stage appropriately or provide the correct taxonomy for an ulceration or skin integrity issue. In our second observation during interview, DON confirmed that the skilled nursing progress note for our resident R2's pressure ulcers was inaccurate and incomplete because it did not include the stage of the ulcers, descriptions of some of the wound beds, surrounding tissue, or any signs of infection. So again, you have mischaracterized pressure ulcers, you have incomplete documentation at play here. And again, this is what they use. They use the policy that you have in-house. They look at the documentation, and then they try to draw a connection between the two. And again, errors etc., can really get you in trouble. So finally, just talking a little bit about risk mitigation here. And I just wanted to provide very simple steps that a facility could take. And many of you know these steps, but I wanted to just re-articulate them and make them extremely simple to understand. One, use systems around wound care rather than ad hoc solutions. So when considering how to mitigate risk vis-a-vis wound care, think about it from a systemic point of view. From the moment that patient enters to the moment that patient leaves, how is the system around wound care designed to prevent to assess risk, prevent wounds when possible, and to treat wounds in an appropriate and timely manner. And really thinking of it as a system rather than pieces of interventions that are disconnected and not harmonious. Number two, simplify your skin and wound care protocols and use them as a framework rather than a manual, and follow them. And basically what I mean is, we know that the survey is going to come in and they're going to ask for that copy of your wound care skin integrity protocol. If you have a 50-page document with 100 things that need to be done, it is more probable that you're going to fail in doing them simply because of the complexity and the number of things that have to be done. Whereas if there's a framework, some people call this best practices, etc., what you have is a document that provides you the flexibility to do what you need to do, and clarity for the staff to follow it, and also does not provide an opportunity for the surveyors to use, subsection 21.4 on page 32 to give you a tag. So again, simplicity over complexity. Make it explicit versus implicit. Be very clear about what the expectations are, and brevity over verbosity. That means, make very short sentences that can be understood, very short commands can be understood by staff across the building, and basically articulating a framework rather than sort of a manual. Another thing for risk mitigation is identify patients at risk on admission and marshal your resources with regard to wound care, primarily towards that population when possible. When you use those risk identification tools vis-a-vis Braden, etc., it allows you then to basically surveil those people to ensure that prevention activities are happening, nutrition, etc. Resources in any endeavor are limited, and in the nursing home, I know they're limited for you folks there. But really marshalling resources towards those people that are identified at high risk allows you to set priorities and really pay attention to those people that present the greatest risk in your building. And again, with MDS, etc., what the surveyors do is take a sample from your MDS data and then use that to identify patients' cases, which they will look at with regard to pressure, ulceration, or wound tags. So if you're able to marshal those resources towards what is going to be reported in your MDS, it is more probable that you will, when the surveys come, have had those interventions in place, have paid the appropriate attention to ensure that prevention has happened, or if ulceration has occurred, that treatment is occurring in a timely and appropriate manner. And finally, when documents occur, document accurately and timely, and bring in the appropriate wound care professionals as soon as practicable. With F686, that second part, those wound care professionals, becomes really important because of those professional standards of practice that we talked about earlier. You want people that, at minimum, have an education in wound care, understand the challenges of wound care in the nursing home space and as a specialty, and preferably are certified and have experience dealing with wounds. And there's actually, if you're looking for a hack, there's a document that was released by CMS called the Pressure Ulcer Critical Element Pathway, which is a great document to review because it's essentially what the surveyors use when they walk into your building. So I'm just going to pull it up here for a second. Basically, it delineates the system of investigation that the surveyors are going to use. And they have, for example, what they should review. So they're going to review the MDS, the CAS, physician's orders, diagnoses, and care plans. They're going to observe how wound care is provided in the facility. And this document actually has a checklist of what they are looking for. So they're going to look for example, our care plan interventions in place, our staff following the care plan. They can look at technique, repositioning, infectious control. In Delaware, there's actually been an uptick in infectious control related issues in wound care. The state's making a huge effort down there with regard to that, and we've seen that. Not so much in Pennsylvania yet. And the next page here, there's sort of an interview process where they will identify the most appropriate direct care staff member, and they will go through this sort of checklist of questions. So they'll ask the resident, did your wound develop in the facility? If so, do you know how it occurred? They'll ask staff a myriad of questions, and you can see all of them there. They include how were you made aware of the resident's daily care needs, what pressure ulcer interventions were used, does the resident have pain, is the pressure ulcer improving, and how is pain related to the pressure ulcer assessed and how often. And when you read the tags, just as human readable, you see them going through this process very explicitly and systematically. So with regard to thinking about your wound care program, if a surveyor were to walk in, would you be able, and would your staff be able to answer these questions? And will you be able to meet the expectations articulated in this document? If the answer is no, then you have to look at your wound care program to sort of close those gaps, because this is essentially the roadmap they use. I won't say against the facilities, but when it comes to facilities with regard to wound tags. And then another page here talks about the record review, and we talked about this earlier. They go into your records and they look at your policy, they look at your documentation, and they see if that's harmonized, accurate, and timely. And then the final page here provides a flow sheet with regard to what they should tag given certain variables. And in position 5 there, it says based on observation, interviews, and record review, did the facility provide care and services to prevent the development of an avoidable pressure ulcer and or promote the healing of pressure ulcer and or prevent or treat an infection? And if no, they cite 3 and 4. And then 1 through 4, they provide off-ramps to cite other things that are tangential to wound care, but does not meet that standard articulated in 5. So again, if anything, if you need a roadmap, I suggest look at that pressure ulcer critical element pathway and reverse engineering it to buttress and make your wound care program stronger. And we've got about 10 minutes. I'm happy to take any questions that anyone may have.
Thank you, Zee, for the great information today. At this time, we will open up the question and answer portion. Please submit your questions using the question box on the right hand of your screen. And we do have one comment, question, thought that I'll read here. It says November is the Worldwide Pressure Ulcer Prevention Day. Any chance that Focus is responsible for dip in the November tags?
It could be. I mean, listen, when I look at this data, it's hard to infer causality. I think that if the argument is that Prevention Day is responsible for added attention with regard to pressure ulcers, I find that a tenuous argument, because when the state comes in, if you remember, they have a sample of MDS data that they've already collected for patients which they are going to review. So that action has occurred prior to November. So I find that causality a little tough. Again, I don't know, but I don't think that's probable.
Okay. Another comment here. F684 specifically says that the Kennedy's terminal ulcer is a pressure ulcer and refers to F686 for care. However, in F686, wording seems unclear whether or not to stage a Kennedy's pressure ulcer. What is your take?
Well, again, I'm not a clinician, but I actually did a talk for our clinical team just talking about the 686 tag. The 686 tag does clearly articulate Kennedy ulcers as something that sort of falls into its own category vis-a-vis pressure ulceration. And from the language and discussions from my team, it's a Kennedy ulceration almost by definition, according to the text of F686, is defined as unavoidable. It depends how you read it, but at least to me and after talking to my team, it seems to define Kennedy ulcerations as unavoidable. But you need to have the clinical data to support that it's a Kennedy terminal. But it's its own little box and seems to place that case as unavoidable and thus probably not falling into getting tagged if you can show that it's a Kennedy ulceration and all care was taken.
Okay, great. It says even if unavoidable, it still needs to be coded as a pressure ulcer, correct?
I would. I can get an answer from my clinical team. I want to be very careful in articulating that. But it seems in my reading that it defines it as something separate and distinct in the new tag. With regard to coding the pressure ulcer, I don't know if she's referring as NDS or ICD-10. I can talk to my clinical team if I can get that person's details and give them a better answer. I don't want to step outside of sort of my parameters as a non-clinician, but I'm certainly happy to get that answer from my team.
It says yes, MDS.
It's MDS. I honestly don't know the answer to that question, but I'm happy to do a little bit more research and give that person further guidance.
Okay, terrific. All right, are there any other questions? Looks like we still have a couple minutes here if we don't have any other questions. And I will be sending out, after the webinar, I will send out Z's contact information. So if you think of anything that you want to get in contact him with, you can certainly feel free to reach out. All right, looks like we do have another question here. It says, thank you. The data was fantastic. Great presentation. At Genesis, we do consider Kennedy's ulcer a terminal, unavoidable pressure ulcer and do code it, at least at this point. Just an FYI for your clinical discussion.
Okay. Yeah, I can see that. Again, it's with regard to there's sort of a disconnect in some way between MDS and the language in the tag. They're related, but not totally in line. And I can see Genesis, why Genesis would do that. But again, it's sort of there's a discrepancy between how they're talking about things and how to code things. And I can certainly see how MDS, would be concerned about that because those quality measures and everything are becoming more important. But I appreciate that from the person from Genesis.
Great. There's a question for me. Is this webinar being recorded? Yes, it is. It'll be available on our website later today, and when I send out the certificates, later today, there will be a link to our past webinars on our website. All of our webinars, except for one in recent, within the last couple of months, has been recorded. There was one on Legionella that was, there was a little snafu in the technology, so we didn't get that one recorded, but we're going to rerun that one along with the West Virginia Healthcare Association in January, so that we'll have a recording of that Legionella webinar. So yes, the webinars are recorded, and you can feel free to listen to those at your leisure. Okay, so we do have another question here. It says, can you tell us what pressure ulcers in long-term care make it onto the quality indicator report?
Can you repeat the question? Sorry, I missed the first part.
Sure. Can you tell us what pressure ulcers in long-term care make it onto the quality indicator report?
Yes, so in terms of the quality indicator report, the numbers that make it onto into the final nursing home compare is the M section of the NDS. So that's M300. I believe through 350, something like that. I can pull that up. But those are the ones that are taken. So you have, number of ulcerations on a person, skin assessment, such 301, 302. So that 300 series is what makes it onto the quality report. And then they aggregate that data, and then there's an algorithm to then articulate it in the nursing home compare database, which is what you're referring to.
Great. This is all great information. Thank you so much for putting on the webinar for us today.
It's a pleasure.
Okay, we do have another question. Does that include facility acquired and hospital acquired?
Yes.
Okay, any other questions? We have about 3 more minutes during our scheduled time here. And just a reminder, let me throw out a quick plug for our other scheduled webinars this month and next. We are working on a webinar schedule for 2018. So if there are any topics that you want us to look into and run for you next year, please send me an email. We're happy to consider that. We'll be putting that schedule together here pretty shortly. For the upcoming webinars, we have a webinar that we are going to get scheduled today. We've been waiting around and trying to get some information from PEMA on emergency preparedness, especially in the light of, the hurricanes, in Texas and Florida, and some lessons learned there. What we can do here in the state of Pennsylvania with our own unique challenges with weather systems and other disasters. So PEMA will be putting on a webinar on Thursday, November 30th at 2 p.m. And we have a succession planning webinar scheduled for Thursday, December 7th at 10 a.m. And it's succession planning within your facilities, not just at the administrator level. It's just thinking about those positions within the the facilities and how to plan for succession, at all levels. So we think that's going to be an excellent webinar as well. All right, I don't see any other questions. So again, just a reminder that a survey will be emailed before the end of the day, and a recording of the presentation will be made available at the PHCA website. Please take a moment to complete the survey, and I'd like to now thank again Zweli for presenting on this topic today. Have a great day, everyone. Thank you.
Thank you, everyone.